All right, continue with the metabolism, the biotransformation. You have this phase 1, and now phase 1 is always hepatic dependent, whereas phase 2 is not organ dependent. So you have phase 1, which is non-synthetic. The drug is oxidized or reduced to a more polar form. So the CYP enzymes, and that's induction or inhibition. In phase 2, the metabolism is synthetic. You're adding a polar group, or it's conjugated to a drug. Something's conjugated to the drug to make it more polar. Why do we do that? And it's usually via the glucuronidation system. And we do that so that we can pee these things out, so to speak, get rid of them. Excretion, exactly. Obviously, if you have poor hepatic arterial flow, what's that going to do to your drug accumulation? Somebody who's in partial liver failure, would you want to give higher doses or lower doses? Lower, right. Right. You have to make adjustments. Yeah, those are the kind of things they would want you to know. Gender and racial differences, the polymorphism are out there. As I recall, the last time when I took my test, they asked about the aldehyde dehydrogenase, which is deficient in East Indians, Asians, not Central or Native Americans. So a lot of people think that because of the old cowboy movies, right? But it's the East Indians that have greater difficulty actually metabolizing alcohol. All right. Pharmacokinetics, elimination, changed and unchanged. Roots is through the kidneys. Disease can have a bearing on that. And then there's feces, and you can expire it. You can even sweat out some of this stuff. Concepts, you want to know the first order kinetics and zero order kinetics. Some examples of that, I think Tylenol is a good example of that, and alcohol certainly is. Half-life, general principles about half-life and steady state to reach concentration. You already know that once you know the half-life, and then clearance. So when you stop taking a drug, how long does it take for you to get it out of your system? What's the magic formula? Same as the half-lives, right? Exactly. 4 to 5 half-lives to get rid of it. So if we're dosing a drug once a day, right, we know that it must have about a 24 or more hour half-life, right? Would you agree with that? Yeah. And if we're giving the person a lot of doses, right, during a day, maybe 3 or 4, then we could probably presume, in general, that there would be shorter half-lives, right? Okay. You want to look at this, how gender plays a role with the absorption, the volume of distribution, how far it gets into the system, and spreads in the metabolism and elimination. So there are differences like with lower acidic environments, exogenous estrogen plays a role, slower intestinal transit time plays a role. There's great, in the volume of distribution, it's greater in young women than men. The protein binding is lower in women. Exogenous hormones play a role as well. And then metabolism and elimination, use of oral contraceptives, and gender differences in the CYP enzymes that we know of. The protein binding is lower in women. Why would that be an issue? What would it do to it? Most of the drug, as a rule, right, most drug, is it free or is it bound? It's bound. Most drug is bound, right? So if you have protein binding is lower in the women, then they may require a larger dose or a lower dose of something. A lower dose, right, right. Not that it would kill them, but they might have more side effects if you give them a higher dose too quickly, right? Okay, good. And then we go to the effects of pregnancy. Big issue, of course. Decreased gastric motility and absorption is an issue. Increased volume of distribution, pregnancy increases estrogen and progesterone, and then increased cardiac output, albumin, and alpha-1C. I think that's acid glycoproteins. I think I've missed something. I think it's acetyl glycoproteins. I'm not sure on that now. It's making me doubt myself. The effects of aging, increased drug levels, decreased protein binding. Because of this is what's happening. Because you're getting increased drug levels because of the lack of protein binding, decreased tissue mass. That's that volume of distribution spreading out. Increased body fat. That's going to change the distribution. Decreased renal functions, diminished hepatic flow, that type of thing. So we tend to want to watch for the elderly. So we start out with lower doses, typically half of what you would give a normal, healthy young person. Decreased drug levels, decreased intestinal absorption, and you get increased gastric pH that can interfere with it. More fat with women? I'm not going there. Okay. All right. Elderly, best choice for anxiety in elderly patients. We had this yesterday with that sample question, right? So we want a short-acting benzo if we're going to do that, such as lorazepam or alprazolam. Of the two, you would probably favor alprazolam because it's a lot shorter acting than the alprazolam. So always know which of the short, intermediate, and long-acting benzodiazepines. That becomes important in distinguishing what you might want to give an elderly person, because they may not put these options up there. They may not put Ativanopter or Xanax. They might put something else, just to see that you know the differences amongst those drugs and which ones are likely to cause problems. The best TCAs for sleep with elderly patients, amitriptyline, we do that, but there is an anticholinergic effect. But you can give very low doses and you're fine. It may be at that low dose that's typically given for elderly people, which could be in the range of anywhere from 10 to 25 milligrams, which is a tiny dose. It may be acting more as a histamine blocker. Same thing with nortriptyline and trazodone. Exercise actually is just as good as taking a medication for depression for them. What determines the release into blood? How much it's bound? And if there's any competition with the binding? How it's absorbed? And then the fat composition. Because most of the drugs, if we're giving something that gets into the brain, you can assume that it's highly lipophilic, right? So if it's lipophilic, and you have more body fat as you get older, it's going to distribute into those tissues as well, not just the brain where we want it to go. So it could have an effect on the response. But exercise is harder for compliance. Yeah, that's absolutely true. Yeah, it is hard. I just try to get people to walk. If I can get them to walk 30 minutes, 5 days a week, I'm tickled pink. All right, where are we? Increased half-life due to reduced liver and our kidney function, volume distribution issue in the elderly, and implications for dosing. TCA used to best avoid orthostatic hypotension. With elderly or a patient with stabilized hypertension, nortriptyline Pamelar is a good drug for them. It just depends on whether they have a heart condition. That's what you'd have to watch for. And then the choice of antipsychotics in the elderly is Risperdal. Most people in an emergency room, you're not going to see them using Risperdal typically. What do most people see when some elderly person goes to the emergency room? If they have to give an antipsychotic, it's going to be Haldol typically. In the range of what? About 0.5 milligrams to see if it does it. But Risperdal is really actually a little bit better for that. It doesn't quite as snow because it's really sedated on the Haldol. Here are the pharmacodynamics, the binding affinities, efficacy and potency, know those concepts. The EC, effective concentration 50, where everybody gets the same, that's the point at which we get effective treatment. And then the LD 50, that's the point at which people go into lethal risk. And then there's these sort of allosteric binding principles, receptor antagonists. And when I went through a bunch of these full partials, competitive antagonists, clinical partial agonists, you can go read through that. Inverse agonists, there's coagonist, works with other coagonists. And there's receptor antagonist, blocks a receptor, and you can get reversible or irreversible. And so the MAOs most of those are irreversible. That's why it takes 2 weeks to undo the damage, so to speak, before you can give something else. You have to clear them for 2 weeks. You all know that, right? Yeah, great. Yeah, 14 days as long. It's just 2 weeks usually is enough. Thyroid functions. So this is clinical medicine. You want to know the symptoms of hypothyroidism and hyperthyroidism. Obviously, they can be characteristic of depression and/or anxiety. What are the common disease states like the Graves versus the thyroid storm, and what does lithium do to the thyroid? We'll come back to that in a little bit later. The questions in the Mass General say 5 weeks. Where the hell did that come from? Which book? The current one? What page? That's amazing. Can you tell me the second edition? Not the third. I got the third. Peter, you saw that in the second edition, or is that what you're saying? It was the second edition. Well, I don't have that with me. Okay. Reason to buy the third. That's ridiculous. Not 5 weeks. I don't think page, but I've seen a few about 5 weeks. It's really supposed to be just 14 days. But again, I don't know anybody using MAOs. You running across patients with MAOs? Anybody? I'm not. Oh, okay. But that's a little different, right, Sean? In test reviews. Yeah, always in test reviews. Yeah, exactly. Yeah, it's a patch, but I think it's reversible. B, I believe. I'm not sure. I haven't looked at it in a long, long time. Yeah, it's non-competitive. Yeah, it's a B. That makes it less problematic. And that's used with Parkinson's patients. I think that's the only time I've ever seen that being used. It's not used for psychiatric reasons. Oh, they're using it as a neuroprotective at the lowest patch? Is there evidence that really supports that? I haven't seen that. Okay. I'll have to follow up on that one. That's a curious one for me. Oh, with elders only. Okay. Parathyroid, we talked a little bit about. Well, that's calcium reabsorption. Simple hyperparathyroidism, hypo. The kidney functions, symptoms of disease states, impairment in glomerular function. What happens when you have glomerulonephritis with lower urine output and hematuria, so you get blood, and then the protein is more evident in the urine as well. And then there's the creatinine clearance you need to know about. And your adrenal glands, they play a role. You need to know the structure and the function of it, the aldosterone, a little bit about what it actually does. The Cushing syndrome is always asked. As far as I know, it's always there. Is anybody that's taken the PEP recently, did they get a Cushing question? Yes, it's there. Right. It's always there. If you see buffalo hump, you got that one right. You know it's Cushing's. That's all you really have to pay attention to. One down. That's right, Tony. Okay. Okay, and then Addison's disease. And that's a deficient cortisol disorder. Leads to fatigue, muscle weakness, orthostatic hypotension, darkening of skin, weight loss, vomiting, headache, sweating, slow onset. And the moon phases is associated with the hypercholesterol, cortisol. You get that hump, too, the buffalo hump, the obesity, and there's some purple stria, which are lesions. They look like stretch marks, but they're purple. Amazon does not have the Mass General Hospital 3rd edition. That's funny. Try again because just because that's where I bought it from. And psychiatry, just try, don't put the Mass General part, just key in psychiatry update and board preparation. They just ran out. Oh, you can buy an electronic one. Just yeah, just bought it. Somebody just bought it. So look again. It's there. But you can also get an electronic version to come down if you want it to be on your laptop. Kindle version, that's exactly right. But you can use a Kindle version on an Apple or a PC. Like I said, I should have some stock in the damn book. I'm selling it today. Okay, and then toxicity, managing overdose, administration of antagonists. Like for opiate antagonists, you're going to give naltrexone. This is one they usually ask about, Mazanil, for benzodiazepine antagonism. Atropine, you're not going to be asked about that for cholinergics, I don't think. Physostigmine might be out there. But almost always. PEP3, was that there? The issue about benzodiazepine antagonism? Yep. They like to hang on to that one for some reason. I don't know why. But there's two, Tony. Wish I would have had the course before taking it. Okay, yeah. Well, hopefully it'll be a lot easier now for you. You'll do fine. You'll get through it. Manipulating pH to decrease absorption and increase elimination with acidic agents. You add alkaline with an alkalinic agent. So this is when you're trying to manage an overdose, right? So if you have something that's acidic, you're going to want to give an alkaline, okay, to break up the absorption. And an alkalinic agent, you're going to add something to acidify it to keep the absorption down. Adrenergic crisis, medical emergency, hypertension, stiff neck, nausea, occipital headache, and sweating. So that's a crisis. Then you have the central anticholinergic syndrome, which is very, very problematic in the elderly. Potentially severe confusion, delirium, dry, flushed skin, dilated pupils. That's a stress-related response, obviously. And the absence of acetylcholine as well. So I'll leave that alone for now. Tachycardia, blind as a bat. This is the saying to help you remember what causes the central anticholinergic syndrome. Blind as a bat, red as a beet, hot as a hare, and dry as a bone, mad as a hatter. Those are the symptoms you see. So you can't see well because what? Your pupils are so dilated, I guess. The red is a beet, the flushing, the hot is there, the skin is hot, your mouth is dry, right? And you're mad as a hatter. Actually, yeah, no, never mind, that's right. Skip. I think they always ask about that. That's a third question. I guarantee you're going to be asked something about this anticholinergic syndrome. I promise you it'll be there. If it's not, I'll buy you a beer or a glass of wine or whatever, or a Coke, whatever you want. And then there are these blood dyscrasias, infections, bacterial, viral, parasitic, thrombocytopenia, associated with some drugs, valproic. So that's a thing you would want to monitor. And in first generation, you see the thorazine, that you can get a reduction in your platelets. And therefore, you're going to do what if you have a reduction in your platelets? Bleed. That's exactly right. Or at least bruise. You'll bleed more easily if you're cut, but you'll also show signs of easy bruising, right? Just like being put on a blood thinner, so to speak, except that the mechanism is different. In this case, it's the absence of platelets, but when you're taking other medicines to get your blood thinner, you're actually messing with the aggregation of the system, which is what an SSRI does too, by the way. And you can see that with SSRIs, where they're not getting thrombocytopenia, they're just getting a little bit more bruisability because the platelets can't aggregate as well. Let's see. And then the agranulocytosis, which is very dangerous, right? Lead to death. So you know there's going to be a question about Clozaril and agranulocytosis. Number 3, I bet their question had to be there too. There has to be one of those because it's death. So anything like that's significant, you know they're going to ask. You just have to think that way. Start saying, well, they got to ask this. This is important. Then there's some of these autoimmune diseases like lupus, and then you have AIDS. And AIDS, they usually ask something about AIDS. And so here's some basic information I threw in there for you. Seems like anything unusual is included. Anything with a high risk is included, even though it's unusual. Because if you're lucky in your entire career of prescribing, you'll never run across an agranulocytosis case. You don't want that, right? I don't want that. Okay, when you do a physical exam, what do we typically do? We look at the vitals. If you're doing in people that are using EMRs, are they doing the E&M codes? Anybody out there with the EMRs doing the E&M codes? Up when you're doing E&M? Well, okay. Who determines whether you can do it or not when you say that? Now remember, CMS doesn't control the world. They just control what they're going to pay for. Okay, so CMS can say, we're not going to pay for this. They're not saying you can't do it. They're saying, we're not going to pay for this. That's a big distinction. And so here in Louisiana, we can do them, but there are problems with it because they may not pay as much as doing a therapy session with an add-on. So we're kind of wondering where that's all going to go now. But what evaluation and management under the CMS guidelines, and the civilians here are already saying we can do it here. Outside of the government, they're saying yeah, we can do it. But who determines who can do E&M codes? Who determines who can prescribe? It's the authority of the state that determines that. And the state can say, we want this, and this is going to happen, and it can happen in the state. So that's what we have here in Louisiana. And partly because we keep very politically active and we wanted to make sure we did this. But under the E&M, we only do 2 areas of physical assessment. Okay, and it is gait and station, and strength and tone. Those are the only things we assess physically. Okay. Everybody has to do vital signs, so we do that. We don't really do like a significant cranial assessment for cranial nerves. Most of that can be handled just by looking at the patient, because if you have you remember what the cranial nerves are? I hope you should know those. Okay. Remember the mnemonic on old Olympus towering top. Anybody want to finish it? Oh, touch and feel. There we go. Okay. On old Olympus towering tops. What was it? I can't even remember that. But anyway, the cranial nerves are easy to remember just by what they do. And the ones that, if you were going to be involved in terms of your drugs, it might be related to I don't think you're going to see any, the only other thing you would notice is if there's any asymmetry of face, if there's an eye droop, if there is an eyelid that's staying open. I mean, these would just be signs that there's cranial nerve damage. If there's a tongue issue where they're showing a paralysis on one side, if they can't move their shoulders up and down and turn their head properly. I mean, those are the basic kinds of things you can do. But you don't really have to test that, because if you watch a person walk into your room and you start looking at how they move their head, how they sit down, how they get up, you can tell a lot just by looking at it. And so we're not trying to do this type of an examination, but they may ask you about the basic stuff about some of these things, okay? And I put the one here, this is the oculogyrate crisis. It's an acute dystonia, involves a sudden but sustained maximal deviation of the eyes, and it's associated with neuroleptic drug treatment. So the eyes will be rolling up suddenly with an inability to control them. It's treated with Artane most of the time. The deep tendon reflexes, again, we're not really doing reflex assessments. You can if you want to, but I'm not going to do that, because you take the responsibility of the outcome if you do that. And then there are these pathological signs. So we have serotonin syndrome. There's some physical signs versus the neuromalignant syndrome. Okay, so our serotonin discontinuation syndrome. So if there's GI versus no GI versus stopped SRI, you get flu-like symptoms, and there's no GI issues with the neuromalignant syndrome. So that's just kind of a way to help separate them out. The laboratory assessments, you get these genetic markers that we can look for. I was reading the chapter in the genetics here, and it was really very good. They tell you a lot of things about genes you're not going to possibly remember, but they also sort of break it down to the point where you can talk more meaningful about the risk of having a disease when you're talking to a patient, given their family history. We assume there will be a question. Oh, you can ask. There'll be a question on neuromalignant syndrome. There'll be one on serotonin syndrome. The discontinuation would be more of a subtle one. There's something. What? Somebody beeped in. I don't know what that means. Did you want to ask a question or something? Everybody's just been typing in things. Yeah. See previous. Oh, I'm sorry. Do the PowerPoints handouts you provided cover all this material? Some of it. I haven't gone through all of it. No, that's your job, because here's what I'm going to suggest to you all do. Is you sit down. If you have people around you that you're studying together, because one of the things about psychologists is they're kind of mavericks. They don't tend to share a lot. They don't try to help each other. So I try to get people past that and try to see each other as more colleagues working together, okay? And if you can, what I would do is if you were with 3 or 4 people around you, and you can even do this, you can just divide up the responsibility, and you have each person work up one of these parts and gets all that information together so that you can have that to easily digest and understand. That's what I'm hoping you will do. Okay? But everything you need, again, I'm going to keep saying this over and over again, is pretty much right in those books that I told you. You don't need to go anywhere else. You can get what you need. There may be a few minor little things that are not there, but at the end of the day, it won't make that much difference because a good score is a pass. Previous lectures too? Yeah, sure. If you haven't. You know, you want to really create a massive kind of book, if you would. I don't think it's with, you know, summarizing this stuff and getting it into some way that you're going to actually remember it. That's the hard part. You have to do a lot of memorization. And it helps if you kind of divide the labor up with people. And so you can do that as a group if you want to, or you can do it as 3 or 4 people, or just do it yourself. It's all up to you. But I think that really helps. And then just kind of answering questions. You can do the psychiatry questions. You can do the ones that I have attached to the files. And then you can even make up your own questions. And you'll know more than you know now. You'll be much more comfortable, and you'll get through that test without a lot of difficulty. But working together really does help. Makes the burden a little less onerous. So we're not really doing genetic markers, but I know they're going to ask you about a few of them, so you want a few of the major ones or the odd ones. And again, those genetic markers are in the book. They're there for you. Imaging, there's some PET studies now, MRI, CTs, and SPEC. Here's some basic information that we've known to be true, the PTSD of hippocampal atrophy, and then you get caudate atrophy with Huntington's disease. In fact, when you're diagnosing Huntington's disease, that's exactly the caudate atrophy is what you're looking for on the scan. Flashcards say all cards as fast as you can every day. Yeah, it's exactly that kind of stuff that can help. You know, it's just getting it sunk into you and putting it in a form that's easy to digest it. Okay. And then reduce prefrontal metabolism in schizophrenia, that's been known. So these are some of those sort of markers out there that we know about. Increased metabolic rates in the orbital frontal cortex and basal ganglia and OCD. We know there's some antipsychotic blockade of B2 and B5, 5-HT2, which is serotonin receptor in schizophrenia. And then there's association of introversion and increased frontal metabolic activity. That's just some of the stuff, and I think what I did was I attached a bunch of those to this. We'll get to that in a moment. Laboratory test, common CBC, differential. Differential gives you all of the sub-white blood cells, okay? Like the erythrocytes, leukocytes, basophils, that type of thing. SMA is a metabolic panel, and that's a 7, so it has a certain number of. There are 7 things you're assessing. You should know those. The ESR, that's a SED rate. That's LFTs is essentially liver function. Then your TSH and your T4 and your B12 and your folate. They kind of want you to have some broad idea of the normal values, but just broad because every lab's a little bit different, and any lab you're getting, there's going to be differences in those numbers somewhat because it's based on the 95% interval for their population of patients. Okay. You're saying the book should be required at the beginning of the courses? Why, Martha, you're talking about sort of giving people where they want to be kind of thing? Is that what you mean? Yeah. Okay. It's an interesting idea because it does put things into perspective pretty well. What else have we here? Oh, these are the labs you would do for neuromalignant syndrome. You're going to do a WEC because you're going to get increased white blood cell. So cytosis, you guys got those terms right. Like it's cytosis means more and leukopenia means less kind of thing, right? Everybody's got that. So if I say leukopenia, that would mean you have a low level of white blood cells. Okay, great. CPK is raised, and that's associated with rhabdomyolysis, which is a breakdown of muscle cells and disintegration of the muscles. You'll see raised LFTs, which is a liver function test, and you'll see a course that is characterized by a rapid onset, may persist for weeks, and it can be fatal. It is an emergency. It's typically treated with bromocriptine, a dopamine agonist. And then you can do a lumbar spinal fluid assessment. We're not going to do that. You shouldn't order it. And then there's an EKG prolongation for arrhythmia. Now, from a functional perspective, I don't order EEGs. I could, but I'm not gonna because I'm going to be responsible for the outcome. So my standard approach is if there's any doubt about the cardiac status of this patient, most people are healthy, so they generally know they have a cardiac problem. But sometimes you'll have elderly patients that haven't been to a doctor for quite some time, maybe 5, 6 years. We don't really know what their cardiac status is. So in some ways, you can try to tease it out by asking about symptoms like shortness of breath or any chest pain or any palpitation type of thing. But overall, if there's any concern, so I just refer them to a cardiologist and let them work it up and get a clearance. Because this is the issue, the QT prolongation, because that happens with those drugs, with many of the drugs, and it can lead to a fatal consequence. Even ACIs like Aricept works a little bit different, but if you have an arrhythmia, even if your QT prolongation is normal, if you have an arrhythmia and you give them something like Aricept, you could set this person into a heart failure. So anybody with an arrhythmia, you need to get a clearance. Okay, refer to GP for labs, especially if the patient has not been seen by an MD while for basic checkup. Yeah, you could do that, but I know what they do for a basic lab, and so normally one of the problems I find with doing that is I'd rather just order up the labs that I think are not necessary and send them to the GP for follow-up if there's anything abnormal. It takes really, in most situations, it takes us probably less than a half a day to get the results. If it's something exotic, it's obviously going to be longer, but the results are sent back real quick. And if you ask for a stat, you can do it quicker if you're in some kind of a crisis and you want to know what's going on. But that's more like emergency room. Does that meet the standard for, okay. Does that meet the standard of if you order it, you are responsible for it? Yep. Yep. That is true. It's like if you order an MRI, you've got to deal with it. You can't just go, ooh, it looks good to me. You have to deal with it. You are lucky you can order labs. Montana, not yet. Okay. That's silly. They should allow you. I mean, if you're only going to let you write, are you writing medications in Montana? Okay. No. Okay. Okay. Yeah, it's always part of the. It has to be part of the prescription law. Whoever is doing that, writing that law, it has to be there. You got to be able to do that. But you don't do it like you can order a CBC with differential. It's like usual and customary labs for disorders and side effects. You won't make these general statements in the law so that you can have a broader interpretation of that and not be boxing yourself into a corner. Because tests will change over time. We want to be able to do all that's possible, even the new developments. Let's see, where else are we? So. I skipped ahead. Okay. So these laboratory assessments, we can do these biochemical markers, decreased CSF, serotonin metabolite, impulsive aggressiveness. And so some of this is out there, low 24-hour urinary NE metabolite, 3-methoxy, 4-hydroxyphenylglycol, seen in bipolar disorders, but most of the time we don't do these types of things. So this is the type of thing that somebody might ask you about, like markers, but we typically don't pursue that unless we're really, really confused. Which will get me to another point. There's a point about the CYP enzymes that are being sold now, that you can get an assay of a person's CYP enzymes, and that should predict which drug you might not want to give and which drug they might be able to tolerate better, that type of thing. Had a client come in with the results of one of those. Honestly, I haven't seen him. You know, the only time I want to do that is if I can't find anything that works. I'm more prepared. It's expensive, by the way. You all are aware of that, right? I think it's roughly $2,000 to $3,000 to do. So she decided she thinks she can't take what's prescribed despite the fact that she's done well on it. Is that what you're telling me? Yeah, that's about right. That's why I don't like to just do those things just willy-nilly. You always, if you're ordering a test, it should be for a reason. If you're saying, I can't figure out which antidepressant's working for this patient, so I'm going to get this test to help me make that decision. Not to tell me what to do, but to help me make that decision. That's the way I look at it. And so why do I want to do this? And again, the people that market this go, oh, you could do it for free for the first couple for free. We'll make sure that we'll get the results right back, and it's really going to help you. Well, again, nobody's going to be that nice to me unless there's some money for them. Okay. And it's just, I just kind of want to do those things cautiously. And if something's really real and it's really, really effective, then it's going to hit the mainstream and everybody's going to be doing it. If it's not, if it's just one of those little flukes out there that everybody's kind of finding another way to make some money, then it'll go away. That's my poor man's philosophy anyway. So what else have we got here? So here are some tissue markers. I put those in there that are known. The substance abuse, alcohol-specific, most sensitive lab for chronic ETOH is the CDT, carbohydrate deficiency transferrin. There is a GGT as well. It's found only in the liver and is the easiest indicator at ETOH relapse, so we use that for relapse, and returns to normal when the patient stops again. Eating disorders, amylase, electrolytes, that's the type of test you'd want to do. So those are specific to certain disorders. So you have some procedural assessments. The pharmacogenic prescription. Last time, when I took the test years ago, they asked about this. Which substances could potentially produce panic attacks, induce panic? And it's sodium lactate, yohimbine, flumazenil, caffeine, and isoproterenol. So that question may still be out there, and I would ask PEP3 if there was a question about that. Not that he recalled. So maybe they did away with that. So I just wanted to make sure it was there just in case, okay? The clinical assessment tools, the AIMS is always asked about. Remember, it's a 1 to 5 kind of a great rating of movement abnormalities. So give every 6 months, higher number, worse. Now, here, if you have a patient, let's say they're on an atypical, they have a history of schizophrenia, and we'll make it real easy, and they're 55 years of age, and you've been seeing them now for 2 years, and you've been treating them, let's say, with Seroquel. He complains of a little sedation, but he's on a fairly good regimen. He's tolerating like 600 milligrams a day, okay? He takes them at night because it helps him sleep. And he's not complaining of any loosening of thoughts or odd other experiences, paranoia or anything like that. So, do you give the actual movement scale? Let's say he walks into the room, sits down, talks to you, ease the conversation. What do you think the AIMS is going to read? What do you think the value will be? It'll be normal. Yeah, exactly. Exactly. Do you need to fill that test out? Not really. You could for practical purposes, but you could also say the AIMS is 0. Once it's in there, it's in there. Okay? It's a report. That's all you have to say. But they want you to know about the AIMS because that's the stuff that you do worry about with the basic antipsychotics. The Folstein mini mental status, they typically like to ask about that one. They want you to know the range of score and what it's likely to reflect. Okay. Number 3, peptide 3. Did they ask about the MMSE? You remember? The mini multi mental status exam, excuse me. They asked about it about all of these measures in one form or another. Right. The Montreal, the MoCA? Yeah, the MoCA's out there, the BLESS dementia scales out there, you need to know that, the Glasgow Coma. These are some of the scales you really have to know a little bit about. You don't have to know a lot about, but basically what is it for. And then what they used to ask in the Folstein, with the Folstein, was that they wanted you to have an idea of what was impairment. So it was like 22 and under. But these are normed at a certain level. The Montreal Cognitive Assessment is a little bit more detailed, has a clock drawing in it as well. It's just like a screening test for dementia or cognitive impairment. And then there are a bunch of clinical rating forms. They want you to be familiar with children and adults. And I put those, they're in the book that you have. There are not many that they ask. Most of them you'll probably be already familiar with, like a Beck anxiety scale, that type of thing. All right, what are they for? What are the assessment tools for? How you might be tracking a patient. Identifying it and identifying the disorder and then tracking them over time. So what they might ask you which of the following scales would be an appropriate test for somebody suffering from anxiety to either verify or to determine the nature of treatment. Which book would the assessments be in? There's a chapter on clinical scales in the psychiatry book. Okay. But I'm not sure they're going to ask you. I'm trying to think. Most of you should be familiar with MMPIs, PAIs, that type of stuff, right? Everybody is, right? They're not going to ask a lot of assessment kinds of questions. It's only within the context of treating somebody or evaluating them, okay, or trying to rule out what you have in front of you, okay? Anybody got a good bipolar scale? I'm always looking for something. There's a MMPI question on the Muse practice exam. Do you remember what it was, James? Oh, yeah. Yeah. Yeah, the Y box is, I guess it's that, it's not as good as I would like it to be. I like the bipolar spectrum disorder. Kind of interesting, kind of a little story. It talks about what this person's like, and they have to endorse what it's like them. But I really haven't found anything I'm enamored with.